Ok, possiamo cominciare con la sessione pomeridiana. Abbiamo parlato molto delle difficoltà di avere strumenti per l'investigazione e per la diagnostica eh, che siano validate a livello transculturale. E questa sessione si intitola proprio Cross Cultural Cognitive and Functional Assessment, e quindi ci focalizzeremo su quali strumenti possiamo utilizzare e su quali prospettive di lavoro dobbiamo avere per la validazione di questi strumenti. Abbiamo un piccolo cambio di programma. Il primo speaker è Professor Nahid Mukadam. It's a privilege for me to introduce Professor Nahid Mukadam, from professor of full professor of psychiatry to the UCL University of London, always interested in ethnicity, in dementia prevention, member of the Lancet Commission for Prevention, and thank you for being here. And please. And she will talk about optimizing interpreter-mediated assessment for dementia, the OptiMed project. Thank you.
Thank you very much. Thank you so much for inviting me to this conference. It's been great to hear all about the IMIDIM project, which has been a very inspirational and something that we can aspire to do in the UK, hopefully sometime. As you said, I'll be presenting the OptiMed project. This is funded by the Alzheimer's Association. And I want to thank Mariam, who prepared the slides and who's been doing the bulk of the work on the project. And then all of my collaborators, most of them from ECRON, who have really helped in conducting the project as well. So as we've been hearing over the last, during the morning sessions, and also we had a discussion yesterday, that European countries have become a lot more diverse in the past few decades, and we need to improve the quality of cognitive assessments that are performed so that they're as accurate as they can be, and so that everyone is getting the right support that they need. Many assessments for people for whom their language is not the majority language of the country that they're in would benefit from having an interpreter to mediate the assessments that they're having done. And as we've heard earlier, sometimes this tends to be family members, which may not be ideal. So we were interested as part of ECRON about the practice of using interpreters across Europe and how this varied just from informal conversations. There seemed to be quite a lot of variability in how interpreters were used in different countries. And through collaborators in Australia, we became aware of this the Mindset training program, which basically trained interpreters to become more aware of dementia so that they would help to facilitate when they're involved in either neuropsychological or clinical assessments for dementia and cognitive impairment. So the overall aim for this project was to adapt that training program for use in Europe. So we first aimed to review the existing evidence, including the Australian intervention, to see what other interventions there were out there that had trained interpreters to work with diverse people who have cognitive difficulties. We then aimed to recruit and engage different stakeholders. So these were clinicians, people affected by dementia, so carers, interpreters as well, people who manage memory services and other cognitive assessment centers, in order to find out about experiences of using interpreters in cognitive assessments in different countries. And then we wanted to translate and adapt the mindset intervention for use in these different countries. So there are 7 different European countries in total. Then we plan to pilot the intervention and modify this based on feedback from interpreters who would ultimately be the recipients of the intervention. And finally, we wish to identify future funding so that we can implement this program more widely and assess its impact. So far, these are the 3 steps that we've completed. The systematic review was, we were really looking for core components and good practice of interpreter training interventions for dementia. We've searched these electronic databases that you see on the screen, and we were looking for any studies with any individuals functioning in the role of interpreters and interpreting for cognitive assessments. And the intervention could be really anything, but it was aimed at supporting these cognitive assessments. So you can see we started off with some quite promising number of records retrieved, but unfortunately, by the time we went through screening and reading full text, we ended up with only 2 articles. So I think it's going to be a question whether we can get this published or not, but we remain hopeful. And in fact, both of the studies that were included tested the mindset interpreter training. And this had 5 components to it. So it was imparting knowledge about dementia. There was a module on cross-cultural communication, information about briefings and debriefings around the assessment. So, speaking with the interpreter about what's expected from the assessment, and then afterwards finding out, what the interpreter thought about the assessment. So not just the concrete data that's collected, but also their general assessment of how things had gone, and more subtle, language or communication difficulties that may not have been picked up just from the structured tools that were used. Then a module on interpreting skills, so how to improve on those, and also interpreting ethics. And obviously the framework for that varies from country to country. So the mindset was just focused on Australia. The studies found that structured training for interpreters improved interpreters' dementia knowledge in both studies. And higher training completion was associated in improvements in communication quality. So when they looked at the whole sample, there wasn't a difference in the communication quality or the quality of interpreting, but for people who had completed more of the training, there seemed to be an effect. And people did quite well on knowledge quizzes around dementia following the training as well. So we are concluding that the components for interpreter training should include these 5 aspects, and that seems to be associated with some improvements in both interpreter knowledge and their confidence in interpreting for these assessments, but also in their, potentially in the skill of actually interpreting as well. So that's being written up, and we're going to be trying to sell it to a journal, hopefully. Then the stakeholder engagement and input. This has been really interesting, and we wanted to explore current practices in these European countries that you see on the screen, to see what the variation was, how interpreters are prioritized or not prioritized within different healthcare systems. So we asked, it was a sort of semi-structured interview, but the main structure of it was we were asking, how do you determine whether someone needs an interpreter? Is this quite an ad hoc thing, or do people, is it part of your referral pathway that, everyone gets asked, about their language competence and whether they need an interpreter? And then once you've determined the need, what's the process of booking it, how difficult it is, who pays for it, are there any perceived barriers or facilitators, and then the experience of using interpreters themselves. Well, first of all, are professional interpreters used, or do services rely on family members or friends, or carers who come to the assessment? And then what have been the good or bad experiences of these kinds of assessments? So we, as I said, we did semi-structured interviews. These were mostly mostly online, just for ease, because obviously it's lots of different countries. We recruited mostly through professional networks via email, so there was some sort of snowballing. And in the end, we had a sample of 25 people, mostly female. Most were recruited from England because we obviously were more familiar with the system there. And it was mostly clinicians. We did manage to get some carers and some interpreters, but they were relatively underrepresented. And then we identified 7 themes from the data. So, and this, I mean, largely, followed the process of, initial referral through to the completion of the assessment. So, determining if someone, an interpreter is needed, how do you get one, the preparation before the appointment, the experiences with the interpreters, the, appointment itself, the assessment itself, whether families were involved in interpreting, how people interpreted. So this was, video, or was it phone or in person? And then finally, how to improve interpreting services. So there were, I mean, it was very interesting to see the variation across different countries. And, there were some places where over time there had been less funding available for interpreters. So not surprisingly, then it became more difficult to book them. I think the general feeling amongst both clinicians and interpreters was that it's useful to have a briefing before the appointment, but often this is limited by what health services will pay for. So if you've got an hour-long or hour-and-a-half-long assessment, and it can take quite some time, especially if you're doing more complicated neuropsychological testing, then sometimes people felt that they didn't have the time to get there earlier, to have a debrief before the assessment, or to stay later because they were rushing to their next appointment. So, how do we take account of that and allow that, because it gives better overall assessment? In-person interpreting was really felt to be the gold standard. Video was okay, but there was the feeling that you lose a lot of nuance if you're on the phone or rather than in person. Another important implication is to have, standardization of booking and considering interpreters and language in all systems. So I think the areas that did best were where the referral form itself had some sort of data capture on language competence, so that it was an automatic consideration rather than people coming to the appointment and then suddenly realizing that, oh, they don't speak the, majority language of the clinic. So then you're scrabbling around trying to, sort something out at the last minute. And there was an appetite for interpreter-mediated training. So many of the interpreters felt more comfortable if they had been in a particular clinical area multiple times. So it's like any of us, we feel more competent if we've done something a few times. So the interpreters, who had done memory assessments, they felt more confident going for more and more. So then the same interpreters tended to be used multiple times, but they felt that if they had some training, then that could, then motivate them to be involved more in those kinds of assessments. So there was considerable cross-national variation in use of interpreters, and I think this is something that needs to be looked at a policy level to be prioritized, because obviously individual clinicians or interpreters have no choice over how these things are funded and prioritized in the system. And then what's currently in process at the moment is translating and adapting the mindset intervention. So we have I mentioned the modules that are there. This is this is sort of a sample of what the modules sort of look like, and this is can be accessed online. So we have been what we've been doing is disseminating the mindset intervention to people from each of the sort of leads from each of the countries. that are involved in order to culturally adapt the materials. So mostly this is around, because, the dementia knowledge obviously is all going to be the same, but mostly this is around, the ethics of interpreting or how the system works. So we're trying to get that information into the training materials. And then we've identified an interpreting service that has now translated the materials into the different languages. We're now looking at those materials and again, very much relying on our partners in different European countries to look at the materials and say, this is actually not accurate. Or so far, the feedback has been that a lot of the translation has been very literal, which doesn't often, it's not in reality how people talk. So that's been the main feedback. And I think we've found this in previous work using interpreting services, is that I think when someone is interpreting stuff and they don't have the clinical knowledge or how to apply it, then often, something gets translated too directly. So we've, for example, had, a trigger in a psychological sense, translated as a literal, like a gun trigger, when we've had things translated into. So it's important to have that knowledge around the sort of cultural context and also the clinical context. And then once this is done, then we will be piloting the intervention with interpreters to get their feedback, modifying it some more, and then hopefully, and then looking at the interview transcripts to then write that up and then get the sort of more final version of the intervention. So future plans are to sort of complete this bit of the translation and finalizing the intervention for different countries, and then to identify future funding streams in order to expand this, implement this training, and maybe do some more formalized testing of the impact in interpreters who receive the intervention. These are some references, and thank you very much for listening.
Thank you, Professor, for this very, very important talk. C'è qualche domanda del pubblico?
Hi, Nahid. Thank you for this talk. My question is actually about once the training is finished and it's available in all these different countries, do you have any thoughts about who would be qualified to give the training to the interpreters? Because I sometimes get clinicians who ask me like, oh, I want to train interpreters. And I've never really thought about when someone would be qualified to actually train someone else to do that.
Yeah, thank you. So the training, the way it's set up at the moment is that it's self-directed. So people just access the materials and read through, and there's some links that you can click on that are videos of like interpreting sessions, so you can see variations and how one style of communication might be better than another. But that's certainly something that we could think about that sort of model of training the trainer as part of sort of future work, to see actually because like many things, maybe maybe we could also compare people who receive the training from someone rather than accessing it just on their own, because I wonder if the engagement and the actual knowledge transfer might be greater.
Thank you. That's such an interesting presentation. Then we can talk in the taxi later. But you were mentioning that you found it complex to find patients and carers to include into your studies, which probably would have given you another dimension. Why was it so difficult to find people willing to participate in something that is so beneficial?
I'm really not sure. I wonder if, because the main way for recruiting has been through, sort of professional networks, but also asking people, to identify patients and carers who might be willing to be interviewed, and obviously we had ethical approval for that, but I don't know if it was that the approach was most often in English and therefore is automatically sort of pre-selecting people who are maybe more confident in English, and therefore it's not that much of an issue for them. We also went through this sort of website, so Join Dementia Research, where people who are interested in research in dementia can sign up. And again, it's an English language website, so it's automatically probably not reaching people that we really want to hear from.
Thank you. Other question? I have one. Do you expect that the advantage of to use this trained interpreter to the investigation, to the clinical investigation, could add some value to the final sensibility of diagnostic pathway, and could increase also the willing of immigrants to participate or the retention in the memory clinic, on the contrary of what happens now?
Yeah, I think that is a good point, and I do think that it is an important question whether it is improving. I mean, because certainly clinically, I feel like it does improve your ability to identify nuances and make a more accurate diagnosis, but that's not ever been formally tested. So that's
It's a
certainly,
further study.
yeah, exactly. We have lots of things to apply for funding for.
Thank you. And another question? Okay, we could leave your tax.
Thank you. Thank you very much.
Grazie. Prossimo speaker è Simone Pomati, responsabile della clinica Centro di Disturbi Cognitivi e Demenze del Maugeri di Pavia, che ci parlerà degli strumenti, quindi Translation and Adaptation into Italian of Cross-Cultural Cognitive Assessment Tools, Basic, RUDAS, and Cognitive Neuropsychological Test Battery.
European Cross-Cultural Neuropsychological
Ok,
Test.
thanks.
Complesso. Grazie Camillo, grazie a tutti per essere qui, grazie agli organizzatori per l'invito. Come sempre litigo con... Ok. Io parto da un concetto che è già stato in qualche maniera espresso prima da Ilaria Cova, che ha a che fare con la necessità di cambiare approccio, cambiare paradigma, considerando che la maggior parte degli strumenti sono stati pensati, sviluppati e costruiti con un contesto occidentale, quindi in gran parte in Europa, negli Stati Uniti, qualcosa nell'Asia orientale. E questo utilizza popolazioni quindi ben istruite, spesso ricche, di paesi democratici, e non tiene conto di tanti aspetti che in qualche maniera possono influenzare la cultura e quindi con la cultura anche la modalità di risposta ai test. Il paradigma quindi è quello dell'eclectic, su cui non mi soffermo perché ne ha già parlato prima Ilaria. Perché è importante l'adattamento? Perché i test, anche se standardizzati, potrebbero non essere generalizzabili attraverso le diverse culture, e perché la traduzione di per sé può portare dei rischi di classificazione. Questo ha importanti implicazioni epidemiologiche, cliniche, ma anche e soprattutto sull'equità, e di equità si è tanto parlato questa mattina. Come vedete nella tabella a sinistra, noi possiamo considerare aspetti legati al paese, alla cultura, alla lingua, e capire in quali contesti ha senso un adattamento, una traduzione o entrambi. La cosa importante è ricordarci che il linguaggio non è la cultura e che la cultura non è l'omogeneità. Anche all'interno della cultura ci sono tanti aspetti e tante sfumature di cui dobbiamo tenere conto. Ci sono tante variabili culturali che possono avere un impatto significativo sulla performance cognitiva. Alcune le abbiamo già viste, sono quelle dell'eclettica, altre sono legate proprio a aspetti come le relazioni interpersonali, lo stato familiare, il primo sviluppo cognitivo, ma anche il concetto di ricchezza, di benessere, di salute, e alcuni aspetti legati al contesto, quindi chi può essere presente nel corso della valutazione e qual è il suo ruolo, qual è l'importanza che viene dato o il ruolo che viene dato. Per esempio, questi sono alcuni dei bias che sono stati ampiamente riconosciuti negli elementi dei test, che hanno a che fare magari con l'orientamento. In alcuni ambiti il sapere che giorno è non ha nessun senso dal punto di vista culturale. Un altro aspetto è legato alla velocità. Mentre per noi del mondo occidentale fare in fretta è sempre stato segno che siamo bravi e che siamo performanti, in alcuni tipi di culture l'andare piano è un'indicazione di una persona che pensa, che sta ragionando e quindi è vista con maggiore considerazione, per cui dobbiamo tener conto di tutti questi aspetti. Un'altra delle informazioni rilevanti che è emersa è legato per esempio agli aspetti visocostruttivi. Noi siamo abituati fin da sempre a disegnare, a costruire cose, però questo potrebbe non essere applicabile soprattutto nei contesti a bassa alfabetizzazione. L'adattamento non è la traduzione è solo una equivalenza linguistica. L'adattamento tiene conto anche degli aspetti concettuali e metodologici. In un contesto ideale, noi abbiamo detto, teniamo conto di cultura, lingua, paese e dobbiamo scegliere volta per volta se ci basta un test tradotto, se è meglio averne uno adattato o se, come succederà auspicabilmente sempre di più, lo sostituiremo con qualcosa di nuovo che possa cogliere i diversi elementi anche di distorsione. Parto per esempio da quello che è la costruzione della RUDAS. Ancora una volta siamo in Australia e in questo contesto fu deciso di creare uno strumento che potesse andare a superare alcuni dei limiti che erano stati posti dai test tradizionali, come per esempio il Mini Mental State Examination, e questo l'hanno fatto andando a includere nel processo di sviluppo del test tutti gli stakeholders coinvolti, comprese le persone che il test dovevano subirlo. E quindi hanno scelto una serie di item e sulla base di risultati statistici hanno scelto all'interno delle varie aree cognitive 6 sottoscale che potessero in qualche maniera costruire uno strumento adeguato. Ne è risultato un test breve, facile da somministrare, che non necessita di materiale particolare se non di fatto carta e matita. Quali sono i punti chiave dell'adattamento? L'abbiamo già visto nella bella relazione che ha fatto poco fa la professoressa Mukadam, in cui abbiamo bisogno della traduzione avanti e indietro da parte di un traduttore bilingue che nella migliore delle ipotesi è una coppia di traduttori, uno che abbia una formazione specifica nel campo scientifico di cui ci stiamo occupando e l'altro che sia naif. Questo per cogliere sia le sfumature del professionista sia le sfumature di chi magari non è familiare con questi item. Quindi una combinazione delle traduzioni, una back translation, una rivalutazione, la necessità di compiere magari dei cambiamenti nelle parole o nelle formulazioni e ancora una volta il test pilota. E vedete questo continuo rimbalzo fra salute e cultura, cui abbiamo bisogno di identificare quali sono i domini rilevanti, capire qual è l'effetto della cultura e vedere quali sono gli elementi eventualmente suscettibili di modifiche e così via, fino ad arrivare a un prodotto finale. Noi possiamo considerare diversi tipi di equivalenza che, come vedete, possono essere concettuali, il significato, semantici, solo la parola, culturali, quindi quanto è rilevante per la cultura, o metodologici. Le linee guida della International Test Commission per la traduzione dei test parte da un punto che sembra poco rilevante, ma in realtà lo è, che è, prima cosa, parlare con gli sviluppatori del test, chiedere il permesso di lavorarci. Poi lavorare sul costrutto del test, il contenuto degli item, il consulto con gli esperti e poi arrivare al pilota e alla conferma. Estremamente importante in tutto il processo di traduzione e adattamento è documentare quello che si sta facendo, perché a posteriori potrebbe poi non essere chiaro quello che abbiamo fatto, ma la trasmissione dei documenti che abbiamo impiegato e delle scelte che sono state fatte, la condivisione con la comunità scientifica aiuta a rifare la stessa cosa in altri contesti. Noi possiamo immaginarci due diversi tipi di adattamento, uno difensivo e l'altro costruttivo, ci piace chiamarli così. In un caso di adattamento difensivo penso a dei trial clinici, magari farmacologici, in cui l'obiettivo è di evitare le distorsioni, trattare tutti allo stesso modo. La cultura è vista come rumore e questo va bene nei setting molto standardizzati, popolazioni molto selezionate. Non è quello che succede nella clinica, in cui il nostro obiettivo è di usare lo strumento e considerare la cultura come una variabile clinica, ma devono essere anche degli strumenti che possano essere impiegati negli setting a basse risorse. Quindi bilanciare fra le priorità di salute pubblica e le priorità accademiche. La qualità dipende dagli obiettivi e non dalle statistiche. Il mediatore culturale, abbiamo appena visto quello che è il suo ruolo, ha dei compiti importanti che sono di chiarire i significati, di mettere in evidenza quelli che sono i mismatch, quindi quello che non va bene insieme, non mi viene mai la parola in italiano per mismatch, e sostenere la comunicazione, ma soprattutto mantenere una neutralità, non deve aiutare, non deve forzare. Può essere marginale nei setting standardizzati in cui abbiamo detto la variabile cultura è vista come rumore, ma è estremamente rilevante nel contesto normale. Questi sono gli strumenti del mio titolo, che sono un po' quelli che sono stati messi a disposizione dalla comunità e disponibili sul sito di Imidem. Li abbiamo adattati, tradotti. Vedete la distribuzione dei paesi in cui questi strumenti sono stati impiegati. La RUDES è quella più diffusa anche perché è stata la prima, però potete osservare che abbiamo a che fare con uno strumento impiegabile nella medicina del territorio, uno strumento utilizzabile come screening e una scala, una batteria da utilizzare magari anche non completamente nei setting più specialistici. Questi sono degli screenshot di quelli che sono gli strumenti, così come sono disponibili sul sito, dove ci sono tutti i manuali anche tradotti in italiano. Diverse delle persone che sono qui dentro hanno collaborato a questo lavoro, quindi grazie a chi c'era. E questi sono alcuni degli adattamenti che sono stati necessari in alcuni casi semantici, per esempio ho riportato da Rudas, nella versione originale c'è cooking oil, perché nei contesti anglosassoni oil può avere tanti significati. Noi l'abbiamo tradotto come olio d'oliva semplicemente per mantenere la doppia parola e per dargli un senso nel contesto italiano. Un altro adattamento che abbiamo scelto di fare era di modificare una delle parole da ricordare, che era il tè, per spostarlo nel caffè, non perché in italiano il tè non sia conosciuto, ma perché abbiamo utilizzato lo stesso approccio impiegato in America Latina e in Etiopia, essendo un qualcosa di più comune, diventava più facile usarlo. Una critica che ci è stata posta è: ma dipende dalla persona a cui lo state somministrando, dipende dalla cultura. L'obiettivo, come avete sentito anche stamattina, è che questi strumenti possano essere impiegati anche nel nostro paese, nella popolazione generale, non necessariamente con differenze linguistiche e culturali, ma soprattutto che possano fungere da base per il mediatore culturale nel lavorare con il paziente. Quali sono ancora le sfide che dobbiamo lavorare? Gli aspetti operativi, la validità nei gruppi eterogenei, la limitata disponibilità di dati normativi, e abbiamo bisogno tanto di una collaborazione interdisciplinare. Messaggi veri da portare a casa è che ciascuno ha bisogno di un test giusto e abbiamo bisogno di rispettare quindi lingue, culture e esperienze di vita, non solo le risposte. Un buon adattamento rispetto alla persona, un cattivo adattamento rispetto al test. Grazie per l'attenzione.
Ci sono domande? Io ho una domanda, volevo fartela sulla... questi sono test di screening.
No. Allora, uno è un test che, se vuoi, equivale al GPCOG, che è il BASIC,
Il basic,
che è di breve durata e impiegabile comunemente nella pratica
la
clinica.
RUDAS,
La RUDAS è un test di screening che puoi mettere nello stesso percorso del MOCA del
MOCA, come il
Clinimental.
MOCA.
L'altra è una batteria che è stata pensata, costruita e che quindi, come le varie batterie, a volte puoi scegliere di non utilizzare tutto, ma che comunque è stata impiegata in numerosi paesi con dei buoni
Sì,
risultati.
sì. No, la domanda era capire quale di questa poteva essere più utilizzata in maniera transculturale per i trial clinici in quanto sensibile al cambiamento nel tempo. Perché quello è un grosso problema che poi fa sì che certi tipi di etnicità non vengono incluse nei trial clinici,
Questo credo che è un dato non ancora totalmente disponibile,
che sarà importante
però ci
affrontare.
lavoreremo.
Domande? Allora,
No, ha detto che viene usata anche negli italiani. Volevo sapere se avete fatto un confronto tra le due popolazioni, migranti italiani.
Allora, è uno di quei dati che presentava prima Francesco Sciancalipore, sono dati nuovi, li ho visti anch'io stamattina, per cui...
quindi è
Posso ripetere?
una miniera di dati che usciranno fuori nei prossimi tempi. Dove era? Sciancalep.
No, se vuole posso rispondere. Allora, rispetto a questa domanda e rispetto a Minimental Moca, la RUDAS non è emersa una differenza significativa nell'impairment cognitivo fra migranti e nativi. Questo fa pensare che effettivamente, cogliendo aspetti culturali, effettivamente ci sia più equità tra i due gruppi rispetto a Minimental, che invece tende a discriminare di più i migranti a discapito dei nativi. Ah, quella non l'abbiamo analizzata.
Ma siamo sugli screening ancora.
Sì.
Ok, grazie
Grazie.
Simone. Allora, presento in italiano Clara Calia, professore alla School of Health of Social Science di Edimburgo, e ci presenterà un talk sulla Cross-Cultural Functional Assessment for Dementia,
Sì,
sempre del
sì,
gruppo ECRON.
sì. Grazie per la presentazione grazie a tutti per essere qua. Io penso che sia un convegno fantastico, dovremmo replicarlo. Esattamente come Paola questa mattina, I'm going to give my talk in English. So sorry about that, but these are terminology that I usually use in English. So as you can see, I'm going to talk about functional assessment, and below there is the reference of the paper that we just published with the ICRON group. So basically, I'm going to give a talk on behalf of several people and a critical discussion that we are having in our group. But who we are? You have been hearing about ICRON whole day, and maybe even before. So few years ago, we met in a conference like this, a few of us, we were 5, and we soon realized that we have the same vision, the same value, the same interest. And then we thought, why don't we come back together and we start having this kind of critical discussion more often, maybe try to collaborate and, sharing together our different vision. This is how we started. And today, as you can see from this slide, these data are a bit old, by the way. We come from 10 different countries. We have like 20 cultural heritage and 21 different languages. Some of us have also personal experience of migration, like myself. So, by the way, from the south of Italy, I come from Puglia. I have to migrate in the north of UK, so in Scotland. Yesterday, there was more Scottish weather in Rome. So it was kind of peculiar. And all of us have a different background. It's a mix of neuropsychology, psychologists, clinicians, academics. And also, what we love about our group that is growing, and there are professors from, like Nahit, that just spoke, to students that are still studying. So the vision that we try to bring together is very rich, and we really value different perspectives. Because at the heart of everything we do, we care about ethics. This is a word that unfortunately has not been used too much in all the presentation today, but I think that all of us, we share the same vision. That is our responsibility to think about how we can change and how we can collaborate to make this change happen. It's beautiful to hear that IMIDEM, also ICRON, there are several initiatives that try to create a group of people working together. And that is at the core, I think, of everyone here. It's very important to start considering the cultural, linguistic, and educational background of the people that we assess. Thinking about using the appropriate measures. So a lot of the talk has been talking about using the appropriate measure. So it's very different to use a translate and validate scale or use and develop a cross-cultural scale. And today my talk is exactly about how this is a challenge, how complicated it is. Thinking about the language, but also update the training and the content. So when I talk about the training for interpreter, but we all know that we need that training at every level. So to improve in the same way, so like that, not some of us might receive some kind of training. And at Wicron, we are trying with our effort to organize a summer school. So it's possible that this summer we might have 2 days of summer school in Copenhagen. We will let you know in case you are interested. So my talk is about the activities of daily living. I don't think that I need to explain in detail what they are and how important they are to make a diagnosis of dementia, and they represent a core criteria. And these help us to monitor the disease progression, the patient care, but also legal protection measures. But we all know that the majority of the tools available has been validated in weird population. Well, we know that the social and structural factors, such as quality of education, by the way, is the next talk, and access to healthcare can influence how cognitive decline manifests. That is detected. So we thought that there is a need for cross-cultural functional assessment, and we also know that in our society, people share different kind of overlapping cultural framework, but we also know that traditional scoring methods often assume equal weighting of all items, which may obscure meaningful cultural variation of different activities. For example, older adults might not traditionally perform tasks such as meal preparation or financial management. Transportation or technology might be less relevant in some contexts. And many functional assessments, as we all know, are validated primarily through expert review, not involving patients and other stakeholders. Also, the methods might vary, pretty importantly from self-report, which have the complexity that one individual lack of insight about their own condition, but also the informal report. We were talking before about using a family member or professional interpreter. We know that a family member might feel sometimes uncomfortable on commenting apparent cognitive decline. And both of them also may be influenced by cultural attitude towards independence on illness. Some other tools are more based on clinical written interviews or performance-based tasks or passive environmental monitoring. We also know that the current practice in cross-cultural functional assessment is very diverse. So there are some translation and adaptation, but also some very good example of transcultural markers, such as the Amsterdam IEDL questionnaire. Unfortunately, although it's a very good and valid scale, this has not been adjusted for cultural education, and the sample, again, is mainly European. So we need to make sure that the sample is different. At the same time, we also have amazing specific tool specific on cultural context, such as the Thai and the Indian example. But their sensitivity for detecting functional decline indicative of dementia is often very low. And then we have scale that are specifically developed with a theory-driven approach for dementia-specific markers. So what we need to try to do is to merge all these approaches in a scale that is able to detect dementia, but is also culturally relevant. So a multi-dimensional approach should be combined objective measure functional decline with person-centered evaluation necessary to capture the cultural expectation, the individual autonomy. So instead of having solely a fixed set of tasks, we should think of integrating standardized functional assessment with person-centered questions. So having more like a flexible modules. And these are 10 suggestions that ICRON, with our different perspective, we just draft and publish in this paper. But this is also a call for action because there is all the study that needs to be done. So our idea is that, first of all, we need to understand the cultural perception of functional independence. Sometimes this might be very complicated, but start understanding this variation is the first step. And future research should identify this threshold, maybe thinking about Delphi studies involving patients, caregiver, not only academics, but also clinicians, for example. Develop this core principle, thinking about the cultural competence and the inclusivity and the standardization. And for example, here, I just mentioned a couple of frameworks that we might potentially use as a good example. Also selecting appropriate measures. So considering there are still not available functional activities validating a cross-cultural setting, what at least we need to make sure that we address this. So when, as a clinician or a researcher, at least report these limitations. And then also when we rely on informant versus informal report. Adapt also existing tools and using, for example, the International Test Commission guidelines. Before this paper, we publish a systematic review about how validation and translation is done. Most of the time, these guidelines are not followed. So at least follow the guidelines when we do an adaptation. Also developing new functional assessment tool, account for differences in the measure subtypes and disease progression, because nowadays just few tests are able to detect this. Thinking that one size fits for all approach might not be appropriate, so necessitating of subtype specific functional assessment. And also, as I mentioned before, incorporating patients as caregivers' perspective and to make the tests more applicable and valid. And then, of course, thinking of integrated technologies, particularly for measuring change over time rather than a single snapshot. So traditional assessment rely most of the time on retrospective report, which might be biased, and we know that memory change over time. So wearable and digital tools enable real-time objective monitoring function. For example, they can track mobility, sleep, daily activities, providing longitudinal data on changes associated with dementia progression. And of course, piloting in multicultural settings. And another very key point that we discuss is addressing the literacy and the neurodevelopmental differences. Thinking about separate modules for illiterate and neurodivergent population, tasks like financial or computer use might show early impairment in literate individuals, but not applicable to illiterate. And especially then for neurodivergent population, particularly for older autistic adults, traditional screening might lack of sensitivity. So assessment should reduce reliance on verbal tasks and focus more on functional abilities over time. And also balancing cultural expectation. For example, Francesco was mentioned before, acculturation is a very key concept if you want to work in cross-cultural setting. I'm an Italian living abroad. How much am I acculturated? I work in an English environment. My friends are English. I'm very integrated. While I work with a community of refugees in Edinburgh, for example, from Syria or Afghanistan, they stick to their community. They are not integrated at all. They don't understand the system. So acculturation should be a factor that we always need to consider when we think about cross-cultural studies. Also, cultural responsiveness might be balanced with detecting dementia-specific impairment. Thinking about potentially an hybrid scoring approach can distinguish cultural norms from cognitive decline, for example, not cooking by role versus inability to prepare a meal. So we need to consider this factor. So this might combine report from performance-based observation or follow-up questions. So this is the summary or the proposed priority that in ICRON we are suggesting. But as I said, this is just the start of work. So everybody is welcome to ICRON. Everybody is welcome to, start thinking together how we can develop a scale that is cross-culturally valid, but also specific for dementia. I'm not going to read again all these points. I want just to also finish to say that I always finish my presentation with this map, which is the Gall-Peters map, because they redraw the map of the world, something that we consider objective, how the world is not. If you see how something objective like the map of the world change over time in terms of power dynamics, in terms of who wanted to be like the stronger at the time, says a lot about who we are and the power that we have. So as you can see, Europe is super small here. It's very small. But in the past, Europe was pitched like a very big piece of the world. So we still need to consider who is underrepresented in our studies. So yesterday I was mentioning the discussion that we had in an important paradigm shift, hard to reach, too easy to ignore. It's very easy to ignore somebody that, for example, come from the south of Italy, is a neuropsychologist. What's happened to the south? The presentation this morning was very important. What's happened to the south of the world in general that are not represented in our studies, in our clinical sample. So yeah, I want to conclude with this. Thank you.
Switchiamo italiano?
Sì, se
Ok.
volete, sì.
Grazie per aver sottolineato etica e inequalities
Grazie.
nella relazione. Domande? Una.
Grazie Clara, perché volevo chiederti in maniera sintetica che cosa ne pensi un po' di tutto ciò che abbiamo all'orizzonte sulla validazione, sul considerare un po' i livelli di autonomia, no? E quindi nel prendere un po' in considerazione tutto ciò che ci proviene adesso dalla tecnologia, no? E quindi capire come possiamo andare verso una validazione di tutto ciò. E quanto dobbiamo impegnarci per poter mettere a disposizione dei clinici degli strumenti validati che tengono conto ora della tecnologia. E poi l'altra questione è che tutto questo mondo della valutazione neuropsicologica, no? Dei test, le scale, eccetera, da anni, ma io credo almeno da una decina d'anni, si parla sempre di test ecologici, no? Cioè di test che in qualche maniera hanno a che vedere con la dimensione quotidiana nel valutare la cognitività o gli altri aspetti. Ecco, secondo me è un aggiornamento, anche se effettivamente questa laboratorio, no? Questa cabina di pensiero su sviluppare dei test ecologici, credo che è qualcosa che ci consentirebbe di fare un passo in avanti nella valutazione.
Nicola, quante cose un sacco di punti. Prima di tutto vorrei dire che uno pensare alle functional abilities è importante non solo per la demenza, ma in un sacco di contesti. Quindi avere cura di iniziare a riflettere sul tipo di scale che utilizziamo e l'impatto soprattutto che poi questi test hanno nella vita delle persone, perché è facile essere un accademico, un clinico e poi non renderci conto che sì, è importante fare diagnosi, però se non, poi non capiamo l'impatto che la nostra diagnosi ha, diciamo, rimane vuoto. L'importanza della tecnologia è un punto assolutamente cruciale, perché di nuovo si hanno un sacco di assumption su quanto le popolazioni migranti utilizzano o meno la tecnologia. Io credo che voglio rispondere alle tue domande e osservazioni dicendo solo una cosa: bisogna andare nelle comunità, cioè non si può fare ricerca o valutazione clinica stando nelle nostre fantastiche aule senza conoscere davvero come vivono le persone, che cosa fanno, cosa mangiano, lo usano per esempio il telefono, come la utilizzano la tecnologia. Io per esempio con le comunità con le quali lavoro, Paola diceva prima, parlavamo di cibo, quanto il cibo unisca le persone, lavorare sulla fiducia e poi uno si rende conto che in realtà loro utilizzano forse il telefonino più di quanto lo utilizziamo noi, perché diventa lo strumento principale con cui, che ne so, parlare con le persone nella loro nazione. WhatsApp per esempio, abbiamo fatto un sacco di studi utilizzando un semplice strumento come WhatsApp. Quindi la tecnologia va utilizzata anche perché bisogna avere una visione a lungo termine, cioè la tecnologia sarà sempre più importante nelle nostre vite. Imparare a capirle e utilizzarle in maniera efficace ci può aiutare a prevenire un utilizzo invece non ottimale, mettiamo così. Però diciamo il punto principale è che quando vogliamo fare qualcosa conviene capire di che cosa stiamo parlando e andare.
Cambiando prospettiva, l'uso delle tecnologie può stressare situazioni che altrimenti non apparirebbero e quindi far emergere prima situazioni di criticità quando non apparirebbero in una situazione più comfort. Quindi è un discorso con cui bisogna stare attenti
Sono
perché
d'accordo.
Noi facevamo un lavoro tanti anni fa con un collega geriatra in cui popolazioni rurali del sud Italia avevano una diagnosi di demenza più tardiva rispetto a cittadini che vivono al centro di Roma. Perché? Perché sono più protetti o perché non sono stressati e quindi emergono i danni funzionali più tardi. È un discorso che bisogna affrontare in maniera da due aspetti.
Assolutamente d'accordo, soprattutto in contesti in cui, per esempio, non tutti hanno la possibilità di avere accesso vicino a un centro, quindi la tecnologia può ovviare. Per esempio, io penso in Scozia, io vivo ad Edimburgo, meravigliosa, al centro della cultura e della comunità, ma la Scozia è immensa, ci sono comunità rurali che praticamente non hanno mai visto un GP, figuriamoci un neuropsicologo. Faccio una breve parentesi sulla tecnologia. Uno degli studi che stiamo provando a fare con il professore Sergio Della Sala è utilizzare una piattaforma che abbiamo chiamato Decode, a breve dovrebbe uscire questo articolo, dove invece di sviluppare dei test, mettiamo in contatto un neuropsicologo italiano con un neuropsicologo polacco, se è un paziente polacco, invece io di sforzarmi di utilizzare il test che è stato validato, eccetera. Cioè contattare direttamente il mio collega dall'altra parte del mondo e quindi, però è ongoing, quindi abbiamo appena iniziato. Comunque grazie per le vostre domande.
Grazie, grazie a te. Ok, let's move to the next presentation. Pauline Narm, correct? Perfect. From Professor of Psychology from University of Paris Cité. And she will talk about innovation in cross-cultural cognitive assessment. Thank you.
Thank you. So first of all, I would like to thank the committee for inviting me. It's a pleasure to be there, and I try to contribute a little bit in the reflection here. I would like to present some very pilot data about a new tool we are developing in France. So this is for diverse population, of course. And yeah, so in France, work on developing tests specifically designed for assessing diverse population began nearly 20 years ago on the initiative of Catherine Belin and Didier Maillet at the Memory Clinic of Avicenne Hospital. So just to understand a little bit the context, the Avicenne Hospital is located in the Seine-Saint-Denis department, which is really near to Paris. And this is the French department where there is the highest proportion of migrants. So more precisely, around 30% of the population here are born outside of France. So it's a big amount. We also know that almost 30% of French native people older than 65 are illiterates. And of course, there are also a high proportion of low-educated people in this department. So they first developed and validated neuropsychological tests to detect dementia in this population. And of course, as you can imagine, they first focus on tools to assess episodic memory. For example, with the 9-image test, maybe you are familiar with this test already. It is now used in several countries around the world and also in India and Lebanon. So it's a very good validated tool. And they also developed another test of episodic memory, which is the associative memory test. And then after that, of course, we needed to extend the battery and the tools we had to assess these people. So we carried with the executive functions. For example, we developed the switching fluency task. And then we are now using also the 5-digit test. And more recently, thanks to a nice collaboration and then the PhD of Renelle Bourdage, we also began to develop some tests to assess social cognition in these populations. However, in France, at least, we still have no validated tools to assess language or even posterior cognitive functions. I mean, to screen for visual agnosia, to screen for visual perception, visual constructive impairments, also to screen for apraxia. So when looking at how these functions are assessed in Europe, at least, it appears that the clock drawing test and some kind of drawing copy are the most commonly used tests. For example, in the RIDAS, you can see the copy of the cube. But we also know that from previous studies that they may be not so accurate finally to assess diverse population. And for example, in a very recent study, it has been shown that a high proportion of non-educated participants without cognitive impairments, they are shown in green here on the graph. So these people, they're at least a proportion of these people scored below the cutoff scores on the clock drawing test. And we also see in this, on the right side of the slide, you can see that these people also produce quite the same kind of error than people with dementia. So yeah, again, this kind of test may be not the most appropriate, the most accurate to assess diverse population. So finally, our aim was to try to develop a new battery to specifically assess these functions, so visual perceptive functions, language, and praxis. First, we selected some tests and procedures based on the expertise of the clinician we had here at the Avicenne hospitals. And following ICRON recommendation, we wanted to develop subtests which may be as cross-cultural as possible. And we tried to do that by choosing items as culturally fair as possible, and also by using quite natural material and paying attention to provide simple instructions, and also to use procedures that allow for the presence of an interpreter. So we call this battery the TFP93. The number 93 is still for the number of the French department, and TFP for test to assess posterior functions. So basically, we developed 3 subtests to assess visual perceptual functions. First, we developed. We adapted a task which is inspired from the BOB, which is the Birmingham Object Recognition Battery. And this is a matching figure task where we ask to the participant to tell if the 2 yellow lines are placed at the same place. So the participant has just to say yes or no. The second subtest proposed in this subtest, this is also inspired from one selected from the BORB battery. This is the overlapping figures. So participants have to show the 2 or the 3 figures that compose the one at the top of the page. And we also selected 10 items from the naming assessment of Multicultural Europe test that has been previously validated. And we selected 10 items from the world versions to assess naming abilities. We also developed or adapted 3 more subtests to assess visual spatial and visual constructive functions. First, we created or adapted a small task from the VOSP battery. This is the dot counting task originally, and then we just changing the dot by symbols just for copyrights. Nothing really creative here. So the participants are just to count how many symbols are displayed. Here we were inspired by the bells test, where the participants must cross all the bells on the page, but it's clearly not accurate and not appropriate for diverse populations. So we made a lot of changes there. We changes items by turn them in color, and they are quite simple objects of daily life. And participants still must cross the sun here. So this is the sun test. Then we selected some simple drawings from the French version of the dementia rating scale that participants have to copy. And finally, we propose a few meaningless gestures to imitate, to screen for apraxia. And again, these are gestures selected from a validated tool used in France. And we selected the gesture that seems quite simple for diverse populations, based again on the clinician expertise in our center. So here I'm going to show you very first pilot data. The test was proposed to 12 patients attending to the memory clinic, and these patients have different cultural backgrounds, as you can see on the slide, and they received different diagnoses following multidisciplinary assessment. So the main aim was just to assess feasibility. So for 2 patients, the test was carried out with a professional interpreter, and we did not observe any difficulties for the interpreter, I mean. We did not observe any difficulties with instruction understanding. And only 1 patient refused to take the SEN test, so just 1 subtest in the whole batteries. Speaking of the sun test, we observed in the 3 first patients a pop-out effect. Indeed, we changed the color to follow some recommendations and to help people with the test. But finally, by doing this, we changed also the nature of the attentional processes that are involved. So we turned back a little bit and changed the sun test in black and white. And it seems quite better now. So very first pilot data. So in these graphs, you will show the individual performance of patients for the first 3 tasks. So overall, we can see first that several patients achieved maximum or near maximum scores, which could suggest a ceiling effect, and which is quite common, in fact, in those kind of screening batteries. However, we can also see 3 points in orange. You can see them. And these patients, for some of the subtests, are very lower score than other patients. And in fact, these 3 patients 6, 9, and 11, they are patients who receive a clinical diagnosis of probable Lewy body dementia. So it makes sense for us in the sense that in this dementia, as you know, these abilities are likely to be impaired. So it's quite encouraging there. You can also see quite similar results here on the subtest assessing visual spatial functions and visual constructions. Then again, some maximum score for a number of patients, but you can see that for the Lewy body dementia patients, so they are represented here in orange, they also score quite lower on some subtests. And finally here on the praxis subtest. So again, there are very preliminary data, but some points seems really encouraging to us. First, instruction seems accessible to diverse population, and even in a small cohort with low education, because we had a lot of patients in this cohort without any diploma. Second, difficulties encountered with the battery seems quite specific to the context of Lewy body dementia. So we need to pursue and then to increase the cohort to verify these first results. So obviously, future studies are needed, and the next steps are to first confirm the interest of such battery in patients with neurodegenerative disorders in this kind of population. And then we obviously need, after that, to study the linguistic, cultural, and also educational effects in healthy population, healthy, diverse population, to hopefully provide some normative data. Thank you, and I would like to thank the main contributors and collaborators here. So obviously the center at the Memory Clinic in Paris, in Avicenne Hospital, and then the collaboration with Sana Franzen, and then also with Marco. Thank you all for this collaboration.
Thank you, Pauline, for this talk. Any question? I have one question in the meantime. Don't you think that this battery is quite unbalanced for visual and praxic and visuospatial competence? I mean that could be overrepresented people with defect in could be target and could be predict more people with posterior disorders, and instead there are probably we are missing something that could be useful for finding people with more memory, verbal memory, or executive disorders. And I mean that this is it's quite easily to transcultural adapt at this very moment, but we are missing some tests that probably are more difficult to adapt
because
in a transcultural way.
Yeah, I totally agree, because it was specifically our aim here, because in France, we already have some good tests to screen for episodic memory impairments. So it was just to complete and then have the whole battery to screen because they are not very sensitive, clearly, but to screen each main functions.
Yeah, yes. Because otherwise some, for example, MCI or some other types of onset of disorders could be...
Yeah, totally agree. Yeah, and even if we already have some good episodic memory tests, in fact, there are also lack sensitivity for MCI clearly, and also for a diverse population who had a higher level of education, which is also possible. So they lack sensitivity. So yeah, we also need to go further with those kind of tests. Sorry, but for the moment, when we are looking for the assessment for diverse population with low level of education, we have two very good tests of episodic memory. We have two good tests to assess executive functions, and then we needed this battery to have a whole battery.
Thank you. And any other question? Okay.
Thank you, Pauline. Very interesting material that you presented. I think that the further step should evaluate how the ceiling effect that you proved goes to match with the defects that we find in more common used instruments such as the Rudas. I mean, the people who fail with the cube but go ceiling, and on the other side, people who fail on the matching of the figure, are they the same that are catched by the Rudas?
Yeah, very good point. We have the data.
How long does it take, this battery?
It's very short.
Very short?
Yeah.
15 minutes?
15 minutes, yeah.
Okay, thanks. Any other question?
Thank you for a very interesting talk. I'm curious, the one patient that refused to do the sun test, I saw it was a Lewy body patient.
Yeah.
why did they refuse to take the
He
test?
already did the Bell's test before because we are doing the comparison.
Okay, thank you.
Okay, thanks. The last presentation of this session is from Renel Bourdage, correct? It's from the same university, University Paris Cité, in the same center, laboratory.
Well, I was before. So I
You
was a
moved.
PhD student, and I was with the Université Paris Cité in collaboration with the Erasmus Medical
Okay.
Center. I have since graduated, and now I'm a postdoc.
There is a mistake inside. Okay. And the talk is on capturing quality of education in culturally, linguistically, and educationally diverse populations. Thanks.
Yes. Yes, thank you. Thank you very much. Hello, everyone. Yes, today we'll be talking about exactly that. How do we capture or how do we measure quality of education specifically? And also, why is it important to talk specifically about quality of education in culturally, linguistically, and educationally diverse groups? I think. Oh, haha. Yes. Okay, so why is it important to talk about education in the context of dementia? Well, we know that, for example, the more education you have and also the higher quality education you have, that this is associated with substantially lower incidence of dementia. So for example, there was a meta-analysis that was conducted in 2015 that looked at over 55,000 people with lower education, over 20,000 people with higher education. And what they found was that dementia risk was reduced by 7% per year in increase of education, which is quite significant. And a more recent study, for example, modeled this relationship between years of education and risk of dementia. And as you can see here, it's quite a linear relationship. And what this means is that we are going to be seeing people with educationally diverse backgrounds, meaning that lower levels of education, literacy in clinics, but this is not only relevant, of course, to native populations of Europe, but also, as we all know, and as has been touched on today, migrant populations. So for example, I'm thinking of some first-generation migration populations in the Netherlands, for example, where they tend to have lower, if sometimes no, education. So this means that we need to take certain things into consideration when working in these groups along the entire care pathway. Now, of course, I'll be touching mostly today about neuropsychological assessments. Now, this is already been mentioned already today, but I actually use the term global north. So most neuropsychological assessments have been designed for populations of the global north. This is also an imperfect term, but generally it means for populations from countries which historically have had access to resources, lower sociopolitical instability, as well as a higher quality of life, which means that incorporated into the very test development itself are assumptions. They assume test takers to be familiar with certain cultural knowledge, and they also assume test takers to have familiarity with certain testing structures and formats, or in other words, test wiseness. And this is the component that I'll be focusing on today. Let's take an example, and this has actually already been touched upon today. Let's talk about education and the MMSC. So let's talk more into detail though. Why does the MMSC not work? So as we've seen, the MMSC, the mini mental state examination, is still one of the most commonly used assessments globally for global cognitive function. And this does not work with people with lower education levels. And this is specifically, we see, generally speaking, on serial 7s. So this is a task where you start with 100 and you have to subtract 7 a few times, writing a sentence, as well as the drawing of pentagons. And if you think about it, this makes sense. Because if you're not learning the skill of how to draw a pentagon in a school setting, then where in everyday life are you going to learn the skill? Have you ever been in a grocery store and someone has come up to you and said, oh, excuse me, can you please draw a pentagon for me real quick? It's just not gonna happen, right? So this is something to keep in mind. But also, it's not only about whether you had access to education. It's also more specifically about what did you actually learn? So for example, this is a study that was conducted in 2018. And what they did is that they compared Chinese participants to Finnish participants and their performance on the MMSE. What they found was that Chinese participants tended to perform better on the verbal memory task, but worse on the drawing of pentagons. And this is despite the fact that they had the same education level. So why? Well, the authors suggest that the reason why is because there's different cultural views, different cultural values in each educational system that emphasize different skill sets or practicing of the different skill sets, which then translated to the test. I will focus on this a little bit more in a moment, but just to drive the point home, and again, this has been touched on a little bit as well. But of course, the consequence of this is that if we have people who are culturally, linguistically, and educationally diverse perform tests with biases, then one of the consequences, for example, is of course a risk of misdiagnosis. So for example, this figure here is from a study that was conducted in 2017 by one of our Ekron colleagues actually. And what you see here is that these are all healthy participants. But if, for example, the Moroccan group had been assessed in a clinical setting, they would have been significantly more likely to have received some sort of cognitive deficit diagnosis, say compared to their Spanish counterparts. And this is probably most likely due to this test familiarity component, right? So the key here, and the message that I want to drive home, is that even if you have a test that's appropriate for lower education levels, it's not just about education level, and it's not just about years of education. It's about what did you actually learn? What was the actual skill? In other words, quality of education. And actually, there are some studies that show that if we take quality of education into account, that this better explains differences in test performance that we can see between groups than, say, just years or level. But then this leads to another question. How do we measure quality of education, right? Or better yet, who gets to define what is good or a good school and what is a bad school? What skills are good to be taught? And in fact, actually, what's interesting is that currently most of the research in education, and that also including quality of education, is out of the United States. So can we ask ourselves the questions of, if we were to take an American's definition of quality of education, what does it mean to have good quality education? Does that apply around the world? Is it the same? Actually, a team of researchers recently had that same question. And what they did is that they took a gold standard, an American gold standard of what quality of education looks like in that definition, and they compared it to other standards, for example, Australia, Kenya, and Nepal. And what they found, somewhat unsurprisingly, is that the American perspective was very Euro, Western-centric and didn't allow for other cultural perspectives of what does a good quality education look like. So this led us, and by us, I mean myself and Sana, but also our collaborators, many of whom you've heard from today, Clara, Runa, Ifna as well. We've asked the question, okay, so what would it look like if we were to ask people of various cultural backgrounds, what do you think is a good quality education? And so we created an interview. This is composed of 12 closed-ended questions. These are questions that are common to that of measuring quality of education. So for example, classroom size, number of teachers. This gives us a perspective on the student-to-teacher ratio. But then very open questions about what is a good school? What's a bad school within your lens, within your cultural view? So I'll show you, we're still working on this data, so I'll show you what we have so far in the Netherlands. So here on the screen, you see two groups. So we have 15 participants from Suriname and 14 from Morocco. Now, these are groups that are quite common to the migration background of the Netherlands. You'll notice that these groups are fairly comparable in terms of age and education. I was going to explain what the BASH is, but that was already done today for me, so that's great. Thank you for that. Makes my job easier. But what I will emphasize is that here you can see that, so the BASH is out of 20. And so you can see here that both of these groups have somewhat higher scores, which means that both groups tend to speak their native language more often in their social environments. So this gives us a little bit more of an idea of what their cultural environment might look like in the Netherlands. And here's an idea of what the closed-ended questions, what those responses look like. So you'll notice here that on some items, the two groups responded quite similarly. So for example, we asked them, did you have access to school materials at home? But what's interesting here is that we also gave people, of course, an opportunity to elaborate on their answers. And actually, many people said, oh yes, I have access to school materials at home. But then when they elaborated, they would say, well, I have access to pens and pencils, maybe sometimes paper, maybe sometimes books if my family had the money. So this speaks to the importance of also collecting qualitative data because this paints so much more of a picture than, say, just quantitative data can. But you also notice here, for example, other items where there's more differences between the groups. So for example, when we asked them whether they had access to a library at school, most participants from Suriname said that they did, but you'll notice that most participants from Morocco did not. And in fact, again, one of those things that gets you thinking, one of the Moroccan participants said, oh, I did have access to a library at school, but I never used it because I had to go home and help with chores. So this kind of paints a picture of, okay, access, of course, is different than opportunity. When it came to those open-ended questions, we have an idea of what people would say when it comes to, okay, this is what a high-quality education looks like. And we did get some answers that we were expecting. So for example, a large number of teachers and good quality teachers. But we also had answers that were interesting, like, for example, there's quite a few people who said, oh, a really good school means that a teacher has time or is able to pay individual attention to the students if need be, that they can address those needs on an individual basis. Regarding the lower quality schools, some people mentioned things about, physical or health safety. We actually had quite a few people mention, oh, we want to make sure the classroom is clean or the bathrooms are clean or that there's not broken chairs. We also had one person say that sometimes there were fights between students and they were kind of left to themselves, no one intervened. So there is a sense of also wanting good physical and health safety. But also we had quite a few people mention, for example, wanting to feel like the environment was warm and welcoming and positive. So there's also this perception of wanting social, emotional safety as well. So this is the kind of the beginnings of us trying to understand and crunch this data. As I mentioned, this is a collaboration, and so I'll give you a quick little overview of what that looks like in the UK. So you'll see here on the left-hand side that we're also collecting data in the UK from diverse groups, Syria, Sudan. So by the end of the study, we'll have quite a richness of different perspectives of different cultural backgrounds, which is really great. And eventually, once we have enough data, we would love to then build into an actual measure of quality of education, but we're not quite there yet. For now, though, I hope I can leave you with the fact that there are really important things to keep in mind when we're working with people who are culturally, linguistically, and educationally diverse. Thank you.
Thank you. And there is any question? Is there any question?
It is late in the afternoon. I think we're all ready for coffee.
No. We need a question. Okay. Okay, I have a question. I have the same question that I made before, but please convince me that is necessary, according to you, is necessary, but this is also extended to the other speakers, it's necessary to have new tools or new validation according to different populations for the same tools. What is better? Because I think that if we could consider the last slide, all the variables that make a difference between different populations encompass a lot of variables that are present in Moroccan and not in Suriname population, for example. But you could use the same test and make specific validation for that population, and you compare the results between the two populations. But according to this different standardization validation, you could have different value of the different items, different reliability tests, different standardization, and different cutoff. It's better to have this or to have new tools?
Sure.
It's a mess, I know. Sorry, we have 4 minutes before the next session.
So I'll give a quick reply, then, anybody else have a different opinion. So if we start validating and translating tests in different languages, this might be a never-ending job. Why? There is one of the main researchers in cross-cultural neuropsychology, Alfredo Hardy, that will recently pass away. They said it was specifically working on linguistics. We have 6,800 languages globally. Okay, so if we start to do this, it's a never ending. And then some communities are smaller. There are not enough people to do the validation study. Okay?
And also, to add to that as well, cultures evolve. Yeah, cultures evolve with globalization. Also, there's fusion of cultures. So even if we were to initiate the work of doing this individualized, it'll never end for just sheer numbers, but also over time.
Exactly.
So do you mean only the verbal mediated test, or all the tests?
All the tests, because previously we thought that like visual tests are culturally like free. We know that is not absolutely the case. So the idea why we are discussing about cross-cultural tests, because there's a completely different theory in mind. So like it's from the start. So and then there will be no difference between are you from Morocco, from Italy. Like it's the same test for everybody. So this guarantee equiness and fairness when we
and also I will add, so my PhD was in social cognition. And so, yeah, of course, on the one end of the spectrum, we can't have one test for every single culture. But on the other ends, yeah, there might be instances where it may be important, for example, in social cognition, to have a little bit more culture-specific tests. I'm mindful of the time. But so I don't know that there's one perfect answer, but I think the cross-cultural is our best bet for now. Okay.
Any other comments?
Another possibility is in considering the adaptation of the tests to evaluate why people fail the test, to consider the types of error and to see if this error can be due to disease or culture. But we must be aware which may be the errors.
Hi, thank you for your presentation. I would like to ask if you gave us a lot of detail about objective of the cultural education. I'm curious about something like the influence of the family, on how it is perceived, the education inside the family, and also about religion. For example, the Indian culture is, they have a very long education in maths, and so that's why they are very good. They have a lot of engineers. So I'm asking if, did you consider in this cultural education also beliefs, religion, and family issue? Thank you.
Yes, so we saw this come through in our quality. So for example, I'm thinking of one participant who said that she couldn't go to school in her time because she was a girl. So this come through in our data, and yeah, it's something that of course we still need to figure out how do we go about best asking. How do we go? And of course, this is just in the Netherlands and UK, but eventually it would be great to collect data in other lenses, other perspectives. But you're right, when we think about education, we tend to also focus on formal education. But of course, this is also applicable in informal, what happens at home. And we know that actually, there's studies on this. We know that what happens at home matters a lot in terms of how people perform on tests because they learn so much. I'm mindful of time. Anyways, but yes, so this is something that we have in mind, but we're still trying to figure out how can we put it into our qualitative assessment.
Thank you all for this very interesting discussion, and move to the next session. Thank you.